So, friends, welcome back, and in this module we will be discussing the ethical issues which are applicable when you practice the art of palliative care and especially palliative medicine. I am Dr. Abhijit Dam, and I am the President of the National Association of Palliative Care for Ayush and Integrative Medicine, and let us begin the module on ethics as applied to palliative care. Eric Cassel, in The Nature of Suffering and the Goals of Medicine, had aptly stated, "The relief of suffering and the cure of disease must be seen as twin obligations of a medical profession that is truly dedicated to the care of the sick. Physicians' failure to understand the nature of suffering can result in medical interventions that, though technically adequate, not only fails to relieve suffering, but becomes a source of suffering itself, and that, dear friends, is not ethically correct." We will start off with a small example. Now, in this picture, this patient whom you see, who is lying down on the bed, she just has one leg, the other leg is amputated here, and you can see a mass out here. So, that is a metastasis to her spinal cord, and in this state she was pregnant and she had a caesarean section in this state, and after the caesarean section some clever neurosurgeon decided to stabilize the spine out here because of the metastasis out here. He said that, okay, I need to stabilize the spine using certain prosthesis. So, financially this lady was dependent on her father. This is her father standing there. She was totally dependent on her father because her husband had left her. Her husband refused to stay with her, and in this state she underwent a neurosurgical intervention that involved a stabilization of the spine. After the neurosurgical intervention, she developed quadriparesis. So, before the surgery she was able to move her limbs, but after the cervical stabilization, which was a purely it was a purely elective procedure just to stabilize the spine without affecting the course of the disease, because already she had multiple metastases. So, after stabilization of the spine was done, she developed quadriparesis. So, now the question is, was the surgery actually justified? And just 3 to 4 months after the surgery was done, she finally passed away. So, now arises the question of justice and beneficence and non-maleficence. We will discuss these issues as the lecture goes, as the lecture progresses. And now, here is another child. This is a newborn child, and during my training in Poland in the field of palliative medicine, this child was born without the ability to breathe properly or without the ability to suckle. So, the child had a tracheostomy done immediately after surgery and a gastrostomy also done, a feeding gastrostomy immediately after the surgery. That is because the mother insisted upon it, and the government in Poland had the resources to get these surgeries done. So, here the financial implications were not that severe, and after the surgery I was lucky to accompany the child back home for the first time, and the child came back home nearly 2 months after it was born. This is another child with a neurodegenerative disorder since birth, and since birth the child, you can see the muscles, all the muscles are atrophied, and the child is on ventilatory support through a tracheostomy which is covered by the T-shirt, and since birth the child is on home ventilation. Now, the question would arise that is it justified to spend so much of resources just to keep such a child alive, where there is no cure for the disease? So, again the question of justice comes and the question of beneficence and non-maleficence come into play. But here more importantly, for us the child is just another patient maybe, but for the mother of this child means the world for her. So, again it comes down to affordability and justice, so many issues which can come forward. Another child, and who again since birth is on domiciliary oxygen therapy, you can see through a tracheostomy. Now, if we are to apply ethics to clinical settings, how are they so important? They can help in medical decision making. We can address issues of futility, where by futility we mean whether this therapy is actually going to help the patient in the long run or not, whether it is justified or not, and especially in a country like ours where we have very limited resources, whether resource allocation should be justified or not, right. Then conflicts of value between the patient, the family and the doctor. The patient might want something, the family might want something, and the doctor would see those issues and the doctor has to balance. At the base of all this is the best interest, realistic goals of care, level of suffering, quality of life which is acceptable to the patient. So, at the end this quality of life measure, this is going to be a very important decision making marker while applying ethics in clinical settings. So, what are the realistic goals of care, like cure of disease, whether the disease is curable, are we going to avoid premature death, whether an intervention will lead to a maintenance or improvement in function or not, whether it is going to prolong life or not, whether the intervention is going to afford a relief of suffering or give a good quality of life, staying in control, a good death and bereavement care. So many issues we have to consider while applying medical ethics. But the most important fact remains that the goals of care can change. What is true today can change tomorrow. Say for today an important thing would be comfort care, while tomorrow that comfort care can be taken over by feeding issues or nutrition or hydration issues. So, goals of care keep on changing. So, we need to keep on reviewing the things, review and review, right. So, review goals with change in health or functional status, in the what setting of care you have. So, you have to be mindful of your resources, where you actually practice, what are the social conditions, what are the cultural conditions out there, whether it is socially and culturally acceptable. Religious factors have to be taken into consideration, and financial viability of the whole thing, long term sustainability of the whole thing. So, there are so many things which need to be considered, and most important is treatment preferences, what the patient wants and whether it is going to be realistic and achievable or not. So, but while addressing ethical issues, there are many emerging problems like inadequate or insufficient communication. People really do not, the doctors or the healthcare personnel really do not have the time or patience to keep on explaining things in detail to the patient and the relatives. Resource allocation, like staff allocation, who is going to take care of addressing such issues, and where is the time or where is the place, you need privacy, you need a separate room. And competencies, like any Tom, Dick and Harry cannot go and issues and address such issues, because you require experience, you need good communication skills. So, good communication skills with a holistic approach, where you are considering the physical, psychological, social and spiritual aspects. So, those things are going to be important. Now, what exactly are these ethical issues? Ethical principles are basically guiding principles for healthcare personnel in work and decision making. So, these are guiding principles. Whenever there is a problem, if you apply the ethical principles, the problem usually you can find a solution coming in. So, there are basically 4 pillars, 4 basic medical principles. The first being non-maleficence. Non-maleficence means, first of all, whatever you do, but before you do anything, please do not do any harm. That is non-maleficence. So, the first principle is non-maleficence, please do not do any harm. And the second principle is beneficence, that is, please do good. But before doing good, please do not do any harm. Because for you, you might think that giving chemotherapy in metastatic cancer might be good. As an oncologist, you might be thinking that way. But giving those chemotherapy in metastatic cancer can have a lot of side effects, a lot of financial implications, and may lead to a poor quality of life. So, that might actually be harming the patient more than beneficence. So, non-maleficence is more important here, that is, please do not do any harm, and only then please do good, that is beneficence. The third principle is autonomy. It is the patient's own body, isn't it? It is the patient's body, it is the patient's suffering. Then who should have the decision making power? The patient, of course. If it is my body, if it is my suffering, I should be the person who should decide about whether I want an injection or not, whether I want chemotherapy or surgery or not. I should be the one who is deciding, and not the doctor or anybody else. Of course, I should be mentally competent for that. And then the fourth principle is justice, which is an equitable allocation of available resources irrespective of class, creed, sex or otherwise. And if we do not follow these principles of medical ethics, this will result cockfights. You will always forever keep fighting. So, this is the popular 4 boxes. One is the medical, the first box is the medical indications, that is diagnostic and therapeutic interventions to evaluate and treat, which basically forms beneficence and non-maleficence, whether any intervention or any drug is going to be beneficial with non-maleficence. The second is patient preferences, that is autonomy, which is very, very important. The third is quality of life. What quality of life are we going to give to the patient prior to and following the treatment? Whether there is going to be an improvement in the quality of life or not, we need to assess that. And fourth and not the least are contextual features, like what is the familial condition, whether the family can afford that sort of care or not, what are the social expectations, institutional availability of resources, financial, legal factors and so on and so forth. So, all these factors have to be considered while making any decision for the patient, and if not, it leads to a state of total hopelessness and helplessness, a state of total pain. So, as I said, non-maleficence means to minimize or to do no harm, weigh benefit against adverse effects for every intervention, and all that is said or done must not harm the patient physically or psychologically. Next is beneficence, that is to produce benefit, to do good, to act in the best interest of the patient, being good, being honest, avoid unnecessary investigations or futile therapies, have a holistic approach to care, and you have to distinguish from paternalism. What is paternalism? That fatherly like attitude, no, you must have this food, or no, you must have this injection. So, usually doctors often resort to this paternalistic type of attitude, and this should be avoided, because the patient is an individual, and as one needs to respect the autonomy of the patient. So, paternalism, like this elderly lady suffering from advanced cancer with multiple tumors, she loves to smoke her chillum, and she has been smoking her chillum for years, for donkey years. So, at this point of her disease, it does not make any sense to stop her from smoking her chillum. So, that would be paternalism. It is fine, she is adult enough, she is aware of her terminal illness, and giving up smoking at this stage of illness is not going to make any difference. If smoking helps to improve her quality of life, so fine. Autonomy. It acknowledges the patient's right to self determination without any prejudice. Treatment only with informed consent, patient's right to decide what they want, and healthcare providers to provide honest and complete information when requested. This was one of my very early patients, and this elderly man, he had a large tumor in his throat, in his pharynx, in the hypopharynx basically, and because of that he could not speak, and he had this feeding tube, this Ryle's tube inserted through his nose into his stomach, through which feed used to be given. And psychologically this elderly gentleman was not very happy, because his son had taken the charpoy in which his father used to sleep, and he used to keep it in the veranda. So, one fine day early in the morning at around 6 o'clock, his son suddenly rang me, gave me a phone call, and he said, you must come fast because my father has pulled out the Ryle's tube. So, I rushed, and this was my very early days in my career in palliative medicine, and without even bothering to ask the patient, I took out a fresh Ryle's tube and started preparing to insert it back through his nose, and the old man, he caught hold of my hand, and because he could not speak, he looked at me in my eyes, and he nodded his head negatively. He did not want the Ryle's tube in, and I did not put it in, because it was his body, it was his suffering, and he had a right to choose, and that was his autonomy. So, autonomy is respecting the right to know the diagnosis, the right to know the various treatment options, the right to know the side effects of treatment, to know the benefits of treatment, to know the harm of not treating, and after knowing all these, the right to decide whether to treat, whether to undergo the treatment or not to undergo the treatment. Autonomy, because you are the boss. Now, what about decision making capacity? You might say that a small child, he would anyway refuse injections and he would refuse hospitalization. Is that autonomy? Not exactly. The child, the person who makes a autonomy based decision must be mentally competent. That means, he must be mentally competent to understand the consequences of the decision and then make the decision. So, in the UK, in the United Kingdom, you have something which is called the Mental Act, and psychologists and psychiatrists have the duty to certify whether the patient is mentally competent to make a decision or not. So, this was an example where this lady, she has a Ryle's tube in, and when I suggested that she should have a feeding tube in place, she at first refused, but then her daughter, she was training to be a nurse at that time, and when her daughter said, no, no, do not worry mother, I will put in the Ryle's tube myself, and then her mother agreed. So, there are ways to do it. You can cajole a patient, you can coerce a patient, but the whole idea should be to improve the quality of life. So, decision making can be task specific, time specific, logical, consistent, and so on and so forth. But as I said, for making decision one has to be mentally competent, and we need to ensure that the patient is mentally competent. For example, this child who is mentally challenged, all his decisions are taken by his mother, this is his mother. So, she is the surrogate decision maker for this child. So, you can have or you can appoint a surrogate decision maker on your behalf. If you And then there is something called presumed consent, where in life threatening situations you can try to save the life of a patient, that is something else, we will not go into that. And when the patient can't decide, then the surrogate decision maker's decision is taken, and autonomy always overrules beneficence. If the patient understanding everything says no, and even if you feel that this particular intervention is going to be beneficial for the patient, but if the patient refuses, that is it, because the patient is the final decision maker. So, surrogate decision making, you have a particular hierarchy of surrogacy, we will not go into the details now. This was another patient of mine, and he had a stroke resulting in aphasia, he could not speak, and for him his daughter, this is his daughter behind, his daughter used to make the decisions for him. So, that was a surrogate decision making. And then there are some things called advance directives. These are legally binding documents that conveys a patient's treatment preferences in certain circumstances. Like I can make an advance directive right now that if I am suffering from a terminal illness, then please do not take me to a hospital, I would prefer to die at home. So, that can be an advance directive, that sort of thing. This is also called a living will at times. This is a format for a living will. In March 2018, in a landmark decision in India, the Supreme Court of India approved passive euthanasia and the validity of a living will. So, it is legal in India. Passive euthanasia was defined as a condition where there is withdrawal of medical treatment with the deliberate intention to hasten the death of a terminally ill patient, but it has to be a terminally ill patient. And a living will as a written document by way of which a patient can give his explicit instructions in advance, like I can give my explicit instructions in advance about the medical treatment to be administered when he or she is terminally ill or no longer able to express informed consent. So, tomorrow if I become unconscious, but I have already made a living will, then the instructions of my living will has to be respected. Then there are so many barriers to completion of advance directives. People do not know about it, believe that the physicians who will initiate such discussions, apathy, discomfort with the topic, feeling that the family would be upset, and so on and so forth. And then there are physician barriers to advance directives. The physicians feel that the patient should initiate, and the patients feel that the doctor should initiate. Then discomfort with topic, negative attitude, lack of knowledge of advance directives, and so on and so forth. But when you come to a village situation, especially in the rural areas, because of the social conditioning out there, the social and cultural factors are very important in proper decision making. Here this is the patient, this elderly lady is the patient, and this is her husband who is sitting out here, and all these people who are surrounding them, these are the local villagers. An important decision was being made whether to shift this elderly lady to a hospital or not, and all the villagers, the neighbors, they all came together and took a proper decision. So, that is also fine, which is culturally very appropriate. Justice, as I said, it refers to equitable allocation of health resources according to need, irrespective of class, creed, race or color. So, whatever or in whichever situation you are, ensure that the patient gets the best, but keeping in mind the availability, accessibility, affordability, all such issues have to be kept in mind. So, in clinical practice, in assessing which principle is more important, give priority to what is in the best interest of the individual patient. So, you cannot make it a blanket rule. Each patient is special by himself or herself. Weigh the possible benefits against potential adverse effects. Communication and disclosure. Patients have a right to a honest and full explanation. This is something which we do not always do. So, why you might argue that why tell the patients about disease and prognosis? Most of the time the family members will say, no, 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 do not tell my father that he has cancer, do not tell my mother that she has cancer. Without giving them information, the patient cannot participate in their own treatment planning. They cannot give informed consent, cannot do advanced planning and bring about foreclosure. If you were to suffer from a terminal illness, would you want the knowledge or not? Would you like to be told or not? Would you not like to participate in the treatment decisions of your own physical body? So, just if you ask yourself the question, you will start getting those answers. So, giving the information, telling the truth, how much to tell, how to tell, these issues will be discussed in the module of communication, where there is breaking bad news and communication, how it has to be done in small bits and pieces rather than a massive feed, right. When not to communicate, when the patient is not competent or the patient has delegated responsibility to a family member. If the patient feels that no, I do not want to know, please talk to my husband or please talk to my wife, that is fine. Or religious or cultural custom requires that the male head of the family is told, in many situations you would get that. Or if the patient refuses, that is, the patient is using refusal, the patient does not want to hear bad news, right. So, there you do not communicate. So, this was another patient of mine, a young boy, and he had rectal cancer. It was a very painful state, but he preferred to be in control. The principle of autonomy, he used the principle of autonomy and helped in participating in the treatment plan, in his own treatment plan. Withholding or withdrawing treatment. Now, suppose if we have started inadvertently, that is why I say that please do not start any such therapy which cannot be sustained or later on you might have to withdraw, because withdrawing a therapy is even more difficult than starting it. There is no ethic in any culture or religion which says that a terminally ill patient must be kept alive by any means. So, you are not bound to keep a terminally ill patient alive by using all possible means, because you have to understand that death is a natural end. Focus on quality rather than quantity of life. See, here you have a patient with COPD who is on oxygen therapy. This is domiciliary oxygen therapy. Acts and omissions. Withdrawing treatment is an act, withholding treatment is an omission. So, there is no moral distinction between withholding and withdrawing treatment. But there are certain special treatments, which have a special status, like artificial nutrition and hydration, where because these are very culturally sensitive, socially very sensitive topics, and here you need a lot of explanations and literally a sort of bargaining sort of thing, and you have to come to a middle ground, because there is no cutout blueprint that you follow this blueprint and you will reach there. No, these ethical principles are just guidelines which will help you guide yourself, but ultimately while going out into the field, you just use this as guidelines and then create your own way, create your own path. So, I will skip the issues of hydration and all, and then there is something called futile care. Physicians are not ethically obligated to deliver care that in their best professional judgment will not have a reasonable chance of benefiting their patients. So, you are not obligated to continue life sustaining therapy where the quality of life is not going to be improved. But still most of the doctors go for futile treatment, because physicians are oriented to curative treatment only. They have no training in palliative care or fear of being blamed for suboptimal treatment, absence of ethical and legal guidelines for end of life care, self determination of patients regarding end of life care issues are not well articulated in Indian constitution. although now since 2000 March 2018, after that landmark judgment, we still have a way forward. And these are guided by certain legal provisions in IPC section 88 and so on and so forth. Euthanasia, which is a deliberate intervention undertaken with the express intention of ending a life so as to relieve intractable suffering, euthanasia does not have a legal standing in India. Physician assisted suicide, where the physician provides the knowledge and means, but act is completed by the patient, this is also illegal in India. Withholding or withdrawing of futile therapy from the terminally ill is not euthanasia, as the intention is to assist natural death and not to deliberately terminate life. And then there is something called double effect, where medications given for one particular effect might have a undesirable effect, which might result in harm to the patient, right. Say the easiest example is that of morphine. For example, you give morphine for relief of pain, but morphine as an undesirable effect in very high doses might result in respiratory depression. You do not want the respiratory depression to happen. What you want? Why did you start morphine? To relieve the pain. So, you wanted beneficence, right. But as a complication, you might have at very high doses respiratory depression. So, that is a double effect. This is not euthanasia. The legal provisions of this of double effect are covered in IPC section 81. And justice, as I said, equitable allocation of resources irrespective of age, sex, creed, class, color, race. And then there is, you have to differentiate between need and want. Need is something without which one will come to be in a state which is contrary to one's most important interests, whereas want is those things one would simply like or desire. Want is a luxury, whereas need is something very basic. So, you need to understand that. And well, this is our hospice at Jharkhand, and that will be all for this module. I hope that you enjoyed it. Thank you.